Hello and welcome to the podcast. My name is Dr. Phil Page. I am a research director and associate professor at Franciscan University in Baton Rouge, Louisiana, in the DPT program. Uh, Over the past few years, we've heard a lot about this concept of athletic recovery and athletes doing all of these techniques and things to help them recover. And it's kind of created this question of what is recovery, what's the science behind the recovery, and how can we as healthcare providers and coaches, trainers, even athletes kind of use the science and the research out there and find out what really helps with this so-called athletic recovery and in an effort to return these athletes to competition or even practice as quickly, safely, and as effectively as possible. So today, what I wanted to do was invite my good friend Mal Malachi, who is the research director at NISMAT up in New York City, has done a ton of research on this topic, is quite well versed. I couldn't think of anybody else more respected and knowledgeable about this topic. So I want to thank you, Mal, for coming and joining us on this podcast to talk about athletic recovery research.
Thanks for inviting me.
So Mal, tell me a little bit about yourself, kind of your background. Why is it that you have so much background and interest in this topic in athletic recovery?
Well, I'm a exercise physiologist. I work in a sports medicine facility, uh, primarily orthopedic related, but I do a lot of sports science stuff. I've been involved in sports my whole life, as many of us in this area have, and at various different levels. I've worked in professional sports as well, and in probably 20 plus years of working with professional sports teams, and I'm asked for advice. Their professional teams are very prey to the snake oil salesmen in the world, and people will say, "Oh, what do you think of this? What do you think of this?" And they kind of use me as a filter, and most of the things they asked me to comment on were things that had something to do with recovery.
Hmm.
So in many sports, the major issue is that you don't have enough time to recover between games, especially when your coaches are trying to hammer something into you and trying to they have different interests and different goals than your overall health and recovery between games. So there's a big need to do other things that might get the athlete better for the next game. And one of my favorite studies in the literature is a study by DuPont in AJSM. I can't remember what year it was, but it was a European soccer team. And in Europe, in your domestic leagues, you play once a week, but you also have midweek games that are primarily in other competitions, European competitions. So if you play in the English Premier League, you'll play your Premier League game on a Saturday or a Sunday, and then your next Premier League game will probably be the next Saturday or Sunday. But on the Tuesday or Wednesday, you might be playing in Europe in the Champions League. So this study took one of those teams and it looked at, if you were playing today, were you playing on 5 days rest or more, or were you playing on less rest? And they had performance metrics, number of sprints, mileage covered, performance win loss. Performance was not impaired when you had short rest versus long rest. But when they look at injuries, you were 6 times more likely to be injured in a game if you were playing that game on short rest versus long rest. So to me, I call that subclinical musculoskeletal pathology. There's something going on in the body. They had done a good job with the recovery, and the output in the game was the same for the athletes, but there was something else going on that was increasing their risk of injury. So, and that's injuries. Most people are doing recovery so that they can just play well and not feel sore and do stuff, but that highlighted to me is the two things go together in terms of accelerating recovery. And at the end of seasons, like right now, we're in the Stanley Cup playoffs, we're in the, I think, NBA playoffs have just started or about to start. These are basically, it's a war of attrition at this time of the year. In about 3 weeks' time, 4 weeks' time, the European Championships will start in soccer. That's a war of attrition. You've got the top, Europe has the top teams in the world in terms of overall ranking in one competition. So it's probably more competitive than a World Cup because you've got fewer bad teams in that competition. So you're playing a tournament over a month, multiple games at the highest level you can play. And that's going to be a war of attrition to see. And it's played at the end of a long season for everybody. So these are the things that people have to battle in terms of how are they going to recover to get optimum performance for their teams.
Hey, that's a great way of looking at recovery that a lot of people don't pay attention to. Is the risk of injury as well as the performance. So I appreciate you bringing that up because that is a big part of what we're talking about. And I think a lot that's fueled this is probably the high value, the dollars that's involved with athletics and these athletes and how much money they lose, the teams lose, the athletes lose if they're not able to perform, if they're hurt, if they're not able to get back into the game. And part of this too, I think, is this natural transition of the old school way of, as you said, the coaches and the athletes sometimes have different goals. And remember, in the old days, we used to do practices without water breaks and salt tablets and those types of things where it was meant to really hammer into you to be tougher, tougher, tougher. And now it's kind of flipped a little bit where rest is now emphasized quite a bit. And I've actually seen in professional locker rooms that they have, and colleges, they have recovery rooms, which are, just areas that are darkly lit, that have reclining chairs, that may have sensory deprivation tanks, all these things. This is a huge market nowadays. It's a huge issue. And I really appreciate the fact that it really goes down to not just performance, but also the injury prevention. And I'm glad that you mentioned that study by DuPont and actually putting some science behind it. So as we move forward today, when we talk about the word recovery, I'm always frustrated because I'll have people or students ask me, how do I improve recovery? Well, how do you define recovery in the first part? What is recovery? And that's what I want to try to do as we start this kind of discussion. And we know that recovery is really about a lot of factors, and rest is one of them we've talked about. We'll talk about nutrition and sleep and the other psychological factors of recovery later in another podcast. But what I wanted to focus on today with you and your expertise is more around what we can use in terms of these techniques, technology, products, the things out there that help us with recovery. So if we could just kind of let's set the ground here. What will we define this discussion on recovery, and what kind of tools are we talking about using for recovery right now?
So when I think of recovery, I'm thinking about getting the athlete ready to perform after having previously performed. So if you're training, if you're training and you decide when you train and you decide when you compete, you're the master of your own domain. You don't really need gadgets or scientifically proven techniques to accelerate your recovery because you can control when to train and when to compete. But most people don't get that luxury in that they compete when their league tells them to compete and they're training to get fit for that and they're always fighting the battle. So in preseason, if you have a proper preseason where, and when I say preseason, I mean what you're doing in your off season to get fit and get ready for your regular season, you don't really need a lot of things to accelerate your recovery because some of these interventions that and we'll talk about the particular interventions, some of the interventions that will accelerate recovery, so to speak, if that's the phrase we want to use, some of those will inhibit training adaptations. So if you're training, you're trying to improve strength, aerobic fitness, anaerobic fitness, you're trying to improve things. When you're recovering, you're trying to avoid losing those things and being unable to perform at the optimal level. So when you're training, you shouldn't be recovering. When you're competing, you need to recover. So that's kind of the gist. And the phrase I like to use is, if you're the master of your own domain, you don't need a lot of these recovery interventions. The only people that might do in that situation is your older athlete. And at the higher level, that's the real difficult challenge. You know, when we're dealing with, at the highest level, when we're dealing with people at the end of their careers, and management have this issue, they want to know, is this guy, is he going to be able to do it again next year, you know, and or is he going to fall off a cliff? And I've worked with teams where I've picked the guy out and I'm going, oh, he's going to fall off a cliff, and the next year he's just as good as he was the last year. And some guys can keep it going and keep it going. And you know, and Tom Brady is a perfect example of someone who he does maybe 20 things for recovery. 10 of them might be total BS. 5 of them might work a little bit, and 5 of them might work perfectly. But if you ask him, what's your most important thing, he might list 10 things that do nothing for him. But if he believes in them and he believes in the regimen, and we get him doing a few things that do work, then, and the ones that don't work don't do any harm, then you don't need to tell the athlete, you know, that's total BS. If it's not doing any harm and it gets them to buy in to doing things that help them recover. Well, a friend of mine's was in the top 30 1500 meter runners in the world. He would go do altitude training in Kenya. He did all things. He was in the world championships one year. I was talking to him, but his biggest problem was, and I told him, you know, all the African runners, they do their training and then they go and lie down and just lie down for the rest of the day. I said, you know what you do? Your biggest problem is you go to the racetrack and bet on the horses. You're standing for 4 hours, 5 hours. He said, that's not how you recover. You know, and he was plagued by injuries. So it's just putting the right steps in place for how you can recover is very important.
I love that. I'm glad that you that was really interesting. What you said is the difference between training and performance in the need for recovery. I think that's a really important point, is that when we're training, we're trying to get the adaptations, and you don't want to necessarily accelerate this recovery. You want to facilitate that adaptation in the training phases in the season. But then, as you mentioned, during the season in performance, it's trying to fit your body into this schedule, which may be weekly, could be bi-weekly, as you had mentioned earlier. And then you mentioned the word that really raises the hair that I don't have on my head, but it's accelerate recovery. I don't understand what we're accelerating. And I think it's become an overused buzzword of accelerate this, accelerate recovery, when we really don't have a good idea of what the recovery definition is. But when we talk about the word accelerate, is that even possible? I mean, how can you speed up the natural processes of the human body? Can we accelerate that?
Yes, well, and I've been a culprit. I use the term accelerate recovery all the time because it sells. You know, when you're trying to, you know, most people when they read your literature, that they look at the title of the study and they look at
Yeah.
the last line of the abstract. If you put accelerate recovery in there, you might get them to read the rest of it.
That's right.
So and you can change how, and in most of these things we look at, people are looking at different blood markers of this and blood markers of that, and everyone talks about inflammation. Mostly I want to look at strength.
Mhm.
I want to know, okay, here's how well your muscle could generate force before this game, here's how well it could generate force immediately after the game, and here's how well it could do the next day and the day after. So, like, take something like baseball pitchers. Mike Mullaney and I just published something on one of our cooling technologies we'll probably talk about in baseball pitchers. And the running joke is Mike's done a ton of work in baseball. He knows the sport better than probably anyone, and I know nothing about baseball. And that's the running joke. I'm doing research in baseball. When I looked at the literature on baseball pitchers, and I said, well, what's the strategy? Why do they rest for 3 or 4 days between? He says, well, they need to recover. And I says, well, how do their muscles work after? And so I looked at the literature. There wasn't one study looking at strength recovery on the days after pitching. Some looked at some blood markers of creatine kinase, some looked at soreness. But I'm going like, well, you could look at performance or you could just measure strength. You probably don't want to look at performance in that, let's see how hard he can throw the day after he's pitched, because there's a certain risk involved, but you can test their strength. So there was nothing there. So we were doing a recovery study in pitchers. We're measuring strength, and shockingly, it was probably the first study that I could find that measured strength. And we measured it 24 and 48 hours after the game. And so I put a lot of emphasis on how the muscle is working. There's other things. I mean, some of our recovery things, we've looked at inflammation. Some have looked at oxidative stress. Some of them look at readiness to perform questionnaires. There's a lot of people do vertical jump measurements. So they'll have people do counter movement jumps, see how high they can jump. A lot of soccer teams do that because it's easier than getting a dynamometer to test strength. And there's basically a myriad of things you can measure. The problem is how well can you measure them, and how noisy is the measurement, and how practical it is. So those are the things you have to think about when you're trying to monitor recovery. But what most people have found is that asking the players how they feel is as good as anything. And while that sounds good, as a sports scientist, that means we as sports scientists are doing an absolutely terrible job. If we can't come up with something that better than how do you feel today is like, and when I'm working with athletes, I like to be able to make measurements on them that they don't even know I'm measuring them. But,
Yeah.
so you don't have to worry about, well, did he give a maximum effort there, or did he do this? If you can, basically being able to assess people without, in their normal path, it's very difficult, but that's some of the things we think about.
That's so true. That when we talk about measure, I'm glad you brought that up. This is another issue that I kind of have that I've seen is people use a lot of these surrogate measures of recovery or inflammation, and they're making this leap of faith that actually has something to do with performance and recovery. Some of these biomarkers like creatine kinase and those types of markers of muscle damage do have this relationship, but I think some people get a little bit off track, and they forget about what you said, which was the real thing we're looking at here is performance and strength, and that we're limited by our ability to go out and throw a baseball the day after. It's really probably not a good indicator, but to be able to measure strength, I think, is an important thing that a lot of people don't look at. And it's not just strength, as you said, it's the ability to generate force, which is a great thing. I know there was a lot of research more on range of motion, and again, those are things that are easy to measure. And when you look at the literature, as we know as scientists, that there's so much variability in literature from good things and bad things. It really makes it important for all of our clinicians, our students, to be better informed consumers of the literature, and not just take things on fate or what's been done in the past. We are only doing this because it's been what's been done in the past. Question the literature. I love what you said about no one had measured strength in recovery in the literature, and it was just something you're like, oh, interesting. I had no idea. So that leads to a lot of the questions about the opportunities now for these kind of myths. These use the word snake oil. I love that term. I use it all the time. Uh, and I agree with you that particularly in athletes, that psychological side, particularly in baseball players, which you may not know, but baseball players are traditionally very superstitious, and they will do the same thing over and over. And I remember, when I was working with my collegiate pitcher, who ended up being a number 1 pick overall. He had this ritual before he pitched every time, and part of it was a special stretching technique and uh, pattern that I had with him. And he would eat sardines and polish his shoes and have a pizza before he threw. And he did that every time. That was his ritual. And whatever made him feel comfortable, that obviously helped his performance from a psychological level. So back to this, we talk about using the word, you said it perfectly, that you use the word accelerate because it's a buzzword. It gets people excited about it. And that what we need to look at is how can we well, let's start with, what are some of those kind of snake oil things that are out there? How do you know, or how can you recognize these kind of recovery tools, things people are selling that are snake oil? What do we look for? What's the good and the bad there in those types of recovery tools?
The first thing is, what is the rationale for what you're proposing that your modality does? So, what is the rationale for why this would affect recovery? And if there's a good rationale and it makes sense, okay, that's good. Then, okay, well, where's the evidence? So now you could have evidence that something works without a rationale that I understand or that you understand, because we're not all geniuses and there's new things come around all the time. But if there's a rationale that we know is total BS, then we're going, well, how does that? And there's some modalities out there that I literally don't know what they're talking about. I mean, so like if we name if we can name Normatec, I don't understand what the rationale for how that would accelerate recovery. And when I read some of their stuff, they talk about facilitating blood flow, and I don't know why that would help with recovery. I've used it. I've seen it. I've worked with teams that use it. Getting an athlete to lie down in a recliner for 20 minutes or 30 minutes is a very good thing. I actually wanted to do some heart rate recovery measures on the athletes when we never got around to doing it, but for other issues and working with professional athletes. But I said, if you get them there, now they're relaxing. But in the bigger picture, the timing of recovery. So if you go play a game, you come off the game, you're exhausted, you're fatigued. That's fatigue. In the several hours, probably 6 hours, things are going on inside your body that make your body feel like crap the next morning. That's when you need to intervene. So if you run a soccer team, because that's a moderate number of players, if you're running a soccer team, you have 11 guys, 10 of them are outfield players. Most of them play 70 minutes or more. Most of them play the full 90 minutes. If Normatec, say, is the best recovery modality, it's been shown to work, you need 10 of them. You need 10 of them, and you need them right there and then, because the horse is going to bolt if you don't do something in the first immediate period after the exercise. So if you take massage, the literature is very weak on the efficacy of massage. The studies in humans show it doesn't really help recovery, meaning if the day after a game you come in, oh, I'm not doing well, and you get a massage and you feel great after the massage. Nobody ever doesn't feel great after massage, but that's not the measure of whether it's helping. The measure is 12 hours later or 24 hours later, are you better and better able to function than you would have been if you had not have had that massage? And that literature shows that it doesn't work. But Tom Best and Tim Butterfield did work with animal models, and apologies to the other authors in the paper because neither of them were the first author. They did work on massage in animal models where they mechanically applied the load. So it was so there was no difference between the application of force and the duration of the massage to the muscles between subjects. It was very well controlled. And what they found was that massage does accelerate recovery of the muscle tissue after experimentally induced damage in animals. but it had to be immediately after the exercise. Doing it the next day didn't help. So that's where, and some people say, well, what's the scientific rationale for why massage would work? And that's a hard one to say, but they had a rationale and they actually showed that it worked in the right circumstances. So it's about trying to figure out how something works, why it might work, and then how can we put it into place. So I've done a lot of work on cryotherapy, and cold water immersion is incredibly popular. And when I looked at it, I said, you know what? It might work, but in reality, you're doing a 10 minutes, maybe 15 minutes of a treatment immediately after exercise for a process that's going to go on for about 6 hours, which you're going to feel the next day. So is that 10 to 15 minutes enough? Maybe we need a larger dose. And so, okay, let's do cold water immersion every hour. So do it for 15 minutes, rest for 45 minutes, do it. You have 11 players in your soccer team, or you have 10 players in your basketball team, whatever that is. How would you practically do that? How would you put all those guys through and who's going to wait in the training room for 2 or 3 different cold water immersions? It's just not practical. So the one interesting thing, I spoke to professional tennis players before last year's US Open, maybe no, a year before, because last year it was deleted from the calendar. And they said, oh, so if we did multiple so that's a single athlete sport. They're in a hotel room. They can have they have cold water immersion tanks in the little blow up ones in their room. So they actually could do it every hour. So they said, so if I do it, I said, there's no evidence out there, because how in God's name would you do that study? But there's a good rationale for it that it might work. So do it immediately afterwards, do it an hour later, and do it an hour later, and then go to bed.
And we're saying there's no study on that, but we need to do that one, is what we're saying.
It's a hard one to do.
It's a hard one to do.
You know, we're gonna I'm gonna do exercise that's gonna exhaust you, make you feel like crap, and then I want you to get in an ice bath for, well, about 15 degrees Celsius is the sweet spot in terms of temperature, and you're gonna do it for 10 minutes, and then you're gonna sit around, and 45 minutes later you're gonna do it again, and then you're gonna sit around 45 minutes, you're gonna do it again. What? You want me to do this, and then I have to come back the next day and you're going to do all these measures? You know, getting people to sign up for that's not particularly easy.
That's easy in college students to do, isn't it? I want to go back to the animal model with massage, because you mentioned that there was this evidence of early or the acute massage right after it was muscle damaging.
It was muscle damage in an animal model, and they did it right after.
And you would why hasn't anyone done that in humans then?
So I haven't looked at the literature on massage in humans. My good colleague, you've seen, co-author Declan Connolly. He was the first author on our very first cherry juice recovery study. He actually sadly passed away winter of 2020, last February. But when we spoke, we did lectures on recovery, and we were at a conference, and there's like about 600 people in the audience, and he got to cover massage. I didn't cover it. And he said, you know, there's not much research out there, and it doesn't seem to work. Timing is an issue. And when it came to the Q&A, someone in the audience said, you know, I'm a massage therapist, and I think it's an absolute disgrace what you just said, and you're demeaning our profession and blah, blah. And he goes, I apologize. I mean, I'm just reporting the literature. And I have to say, I mean, I've never had a bad massage. I'm going, but so what the literature is, there's studies there that have done it immediately afterwards, but were they sufficiently, was a sufficient number of people in the study? Did they look at the right measures? And did they do the right exercise to provide enough damage or something, enough of an insult to the body that you could measure? okay, the control group had this much of a decrement. So there's so many studies out there that show this doesn't work, whatever, something doesn't work. And when you look at the control group, well, the control group didn't have much of a change. If you don't have much of a change in the control group, what are you affecting with your intervention? You have to give yourself a chance. So that's so in terms of the massage, why the human studies haven't worked. Maybe more recently, I haven't checked the massage literature, you know, in the last 12 months or so if something's come out, but that's it's about the technique and the timing and getting the right measures. And you know, there's potential, and a lot of we are, you know, we have this line, we are limited by what we can measure. So if you're measuring, so, and even if you're measuring something that's important to measure, but you're not doing it well, you know, oh, well, it's been shown to be reproducible in these 3 studies. Yeah, but is it reproducible in your hands? And I see guys collecting data all the time, and they're collecting, say, strength data on person day 2 after an insult to the body, and they're doing the strength, and they're talking to the person while they're doing the strength measure, and then somebody comes in, can you fit in a patient at 3 o'clock today? Oh, no, I got this eval. And I'm going like, you're trying to make a scientific measurement. If you were doing bypass surgery, would you just stop and like go on your phone? And, you know, it's the noise in the measurements. When I look at studies and I say, well, look at the noise in the measurement. It's totally not reproducible. Well, it's a reproducible measure. And I said, well, it wasn't that day on those people. And those are the type of problems. It's the sanctity. What is the sanctity of the data in order to assess whether things work or don't work?
That's just another great research consumer point that I always try to make is there's so much in the details of these research projects, and stop reading that last word of the that last sentence of the abstract, which is, like you said, it's clickbait. It's to get you to read the whole thing. But what is interesting when you said that, it of just, you know, you see something doesn't work. Well, that doesn't mean that it doesn't work. It meant that that intervention, that study, that dose, really important. That and what's even more interesting is when you look at medications, and they all have these dose responses that have been well established in the literature through these studies, and yet we will take an intervention, and I use like topical analgesics as the example. And they would say, well, when they applied the topical analgesic, it wasn't effective. Well, how do you know that you had the right dose to begin with? You don't do the dose response studies that are needed before we get to the efficacy studies. That's a huge problem in our approach to treatments and things like that. And like you said, we have a rationale, we have animal evidence, we have mechanistic basic science that tells us this, and then we jump straight to, does that treatment work, without doing the intermediate steps of finding out what is that dosage that we need. Which is why that, like you said, the animal model was important, because it actually was very structured in how it measured the amount of stimulation, not and the damage, the exercise to get you to that damage, and then the actual intervention, which is hard to replicate. And we need obviously more of those pragmatic type of interventions. You also mentioned earlier blood flow, and that was another thing that always irks me, is that they have all these modalities and things that they claim increase blood flow, like that has an effect on recovery. And I'm not sure where that comes from. I think that, and you'll see everything out there improves blood flow. And that is a leap of faith again, that that is somehow helping to perfuse the tissues, recover them, or whatever it is. And it's kind of like what I use, that term of using oxygen on the sideline. You can't keep putting more O2 into the cell. It just doesn't have any more room. It's already saturated. So how much more blood do you need, you know, for this recovery?
The athlete is totally perfused. I'll give you two examples. One, not one actually very not tragic, could have been tragic example. The how perfused our bodies are when we're exercising. I'll start with a simple one. I went to a dentist. They wanted to take a tooth out or something. I went straight after playing a soccer match. They gave me 10 lidocaine injections. because I just come to a soccer match and the lidocaine goes in here and goes boom, it's gone. And then I asked the dentist, well, I just played a soccer match and it was the summer, so it was 100 degrees out, and I'd probably lost 4 pounds of water weight. But and so the lidocaine couldn't work because everything was perfused. My blood flow, any athlete's blood flow, I'm just an old guy, and when they exercise. So the story of Fabrice Muamba is one of the greatest stories in sports medicine. He played soccer for Bolton Wanderers. They were playing Tottenham Hotspur in the FA Cup. It was the main televised game in Britain. He collapsed on the field, cardiac arrest. He was dead. His heart was not beating for 78 minutes. They zapped him on the field. They got him off the field. They got him in an ambulance. They took him to a specialized hospital, which was a little bit farther away than the nearest hospital, the Heart Hospital, but one of the top places in London. The game was in London. They induced him in a coma as soon as they got to the hospital. 78 minutes without a heartbeat. Manual compressions continuously from the minute he fell, manual compressions. They woke him up on the Monday morning and they don't know, is he going to be brain dead? And the doctor said, hi, I'm Dr. whatever, I can't remember his name right now. Fabrice, it's nice to know you. I hear you're quite a good soccer player. And the guy, he's just woken up and he says, I try to be, or something to that effect, which was a kind of a joke, like a clever reply. And the doctor said, I knew right there and then he had full brain function, because if you've got impaired brain function, you do not have a sense of humor. Right. And he said it was just one of the best moments of his. But the reason why he didn't have brain damage without a heartbeat for 78 minutes and just people manually compressing his chest was all his vessels were wide open. The blood flow to his brain was never interrupted because it was in the 40th minute of the first half. He'd been running around. So when people say we need to facilitate blood flow after exercise, I'm going like, what are you talking about? There's nothing. The blood flow is perfect after exercise. So I mentioned earlier cold water immersion and the limitations. And the limitations might be that one dose is not enough. Mm-hmm. So that kind of leads into the research we've done recently over the last 4 or 5 years on what's called phase change material cooling. Mm-hmm. So we found out about this technology, and it's used in computers for cooling computers, but essentially it's taking this liquid form that can freeze into a solid at a given temperature. The ones that we work with freeze at 15 degrees Celsius. So that's cool, not cold. And you get big blocks of it. And when I saw it, I said, if you can make some of those for me and get me some compression shorts, if I put them inside compression shorts, I know I'm going to accelerate recovery from exercise. Because what I can do with that, the game changer was, you've got these pads that are about the size of your thighs. So they'll cover your whole thighs, and you put them inside compression shorts. They stay at 15 degrees Celsius for at least 3 hours.
Wow.
So you can put them in your shorts, go to the movies, go to dinner, go to bed, where you don't have to stay in the training room to do another cold water immersion and another cold water immersion. And so in our baseball study, and the pictures, we had one across here and one across the supraspinatus. Ideally, we wish it had gone over the infraspinatus as well. They're not really made to fit the shoulder, but we figured a way. Mike got compression shorts with the guys, and the pictures, they would finish the game, we'd put them, and then they would go off with their girlfriends, and we would text them, and they would send us a picture from dinner, from the bar, from wherever, and they'd be wearing them, and we'd make sure they wore them for the 3 hours. But it's delivering an intervention that does not interfere with the rest of your activities. You can do stuff. We did one field testing. After we did our pilot study, we did field testing with a professional soccer team in England. They had multiple away games where they had to have a 3-hour plus bus ride after the game, and it was evening games. Mm-hmm. So that was perfect for us to do the intervention while they're in the bus, because then we get to see that they're not blowing it off. They were 20, 21 and 23-year-old kids. You know, you tell them they're professional athletes, they're not necessarily going to be lying at home with a cooling intervention after a game, but they were when they're stuck on a bus. So it gave us a way to capture them, make sure they were doing it, and dramatically accelerated the recovery on the days after exercise. And when I say dramatically, their strength loss, they had minimal strength loss when they wore the cold packs after a game. And so if you're playing tonight, you'll randomize, you're going to wear the cold packs after the game. Next week, that away game, and next week you're going to get room temperature packs in your shorts. And what we told the athletes is we want to see how compression shorts affect recovery, and should we put warm, or it wasn't warm, it was room temperature, warm or cold packs in. We didn't tell them what it was. We were studying, so it was well controlled, and it showed that it works. And it's because we're capturing them pretty soon after the game, and we're capturing them for 3 hours. That's getting to the dose. We know that we're getting an effective dose. And the mechanism is, talking of blood flow, is we're reducing perfusion of the muscles. We're reducing blood flow to the muscle. It'll decrease the metabolism of the muscle. So what you have is you have an exacerbation. So at the end of the game, there's some tissue disruption. If you look at it from a muscle damage perspective, there's some sarcomeres there that have been disrupted.
Mm-hmm.
It doesn't hurt, but it'll hurt the next day if you don't do something about it. So there's an exacerbation that occurs after the exercise that if you can stop that exacerbation, you've accelerated recovery. Essentially, that's what accelerated recovery means. You're stopping the post-exercise exacerbation of the damage. And that's what our phase change material cryo intervention does. And we've increased the dose, but we've increased the dose in a practical way. Mm-hmm. People can do what they want to do. You could go to, if you're a professional, you could go to team meetings, you could do whatever. You're having the treatment while you're doing that.
Yeah, that's very, very interesting use, and I think more appropriate. That acceleration it's like the opposite. It's that you're just not letting it slow you down.
Yeah.
In the recovery.
And there's no reason to do it the next day. You know, these interventions where you do it, the horse is bolted the next day.
Right.
What you're trying to affect is what goes on in the hours after the exercise. That's probably why the massage immediately afterwards works versus the next day.
Right. And you know, this goes back to the old lactic acid myth of causing that soreness in the next day. And I think it was back in the 30s that it was shown that it's gone within an hour.
Sooner than that, more recent than the 30s too. People still
and people are still saying it's lactic acid when we know it is muscle damage. It's micro damage to those, as you said, sarcomeres, which you don't feel at the time, but it's the residual kind of from the damage. And when you and I first talked about phase change, I was very interested because as an athletic trainer for many years with baseball, that's what we did. And ice was the thing that we would put on shoulders. And back then, which was about 30 years ago, there started to be this pushback on the ice. And the theory was that you were, even back then, 30 years ago, we knew that it was micro damage to the sarcomeres, and we were seeing disruption in the Z lines. I did a lot of my master's work was around that, the eccentric exercise and late onset muscle soreness. And it seemed that applying ice immediately was the thing to do to reduce that injury, that secondary hypoxia, that problem that we were treating our athletic injuries with. And then there was a big pushback on using ice for that you were inhibiting the blood flow, and that's what you needed for the recovery and all these things. And what we found in some studies was that ice as applied to the shoulder immediately after pitching, for example, wasn't that great wasn't that much help in changing recovery. Mm-hmm. It didn't mean that it didn't have an effect in injury, right? So we would still apply ice immediately in the acute phases of injury, but when it came to recovery, ice probably wasn't as effective as we thought. And then I started thinking, well, you would put an ice pack on and it would be very cold. It wasn't 15 degrees Celsius. It was closer to that 5 or 0. And when you put it on, what happens? It heats up. In 20 minutes, that ice is melted, right? So we weren't able to get that dose that you talked about, which was really important. Was we were applying ice and we thought we were applying a 20-minute dose, but that may not have been the right dose that we needed. And I felt that it was just amazing that you had come up with that idea that what if we were able to produce that cooling for a longer period of time at a slightly higher temperature. I think that's the sweet spot, and I think that what you've done is a tremendous step in the right direction.
There is some stuff coming out, so I should credit Susan Kvetchin did her whole PhD on this phase change material cooling, and Glyn Howatson, who was her primary advisor at Northumbria University in England. And they've been talking to me recently about the sweet spot might be 15 degrees Celsius might have the best effect on reducing muscle perfusion, better than even colder, even though colder will reduce the muscle temperature more.
Right.
So there seems to be a temperature dependent effect on how well you can reduce the perfusion to the muscle, which I'm not up on that literature myself, but that's where they're thinking. They were recently talking about this and they were excited as this really kind of explains what our mechanism is, why this PCM, and why we went with 15 degrees Celsius as well. That's what cold water immersion reviews say the average temperature was. And if we went colder than 15 degrees Celsius, the phase change material would melt faster,
Right.
and it wouldn't last 3 hours, it would last 1 hour, maybe less than 1 hour.
Yep.
And so there's other companies that have coming out with these phase change material things that can mold around a joint. So it's little cells and I go, no, you've missed the point. If it's a small cell of liquid, that will melt in 20 minutes. It'll be, there's no competitive advantage there. So there's practical limitations. It has to be a big block of hard stuff, which you can't wrap around a knee. And so there's limitations to where and how it can be used. If you can get it around big soft tissues, and that's why we're looking at muscle recovery, because our major muscles are big and soft. So it fits and it works, but it's not the perfect thing in the world. It's, oh, here's where it'll work. It'll work in this environment.
Yeah, and I think that as technology improves and we continue to move forward, all these types of things will continue to get better. We have to be, I think, vigilant as clinicians, as researchers, to stay on top of the science, to make sure that we're not, first of all, doing harm, obviously, but in reality, everyone's time and money is so valuable that why are we wasting time with these types of interventions that don't do anything? Is there something that we could invest our time and money in, even though there might be some psychological benefit to doing some things that don't have harm? At the end of the day, what we really need to be focusing on are the things that are helping people. And I think that using this whole anti-ice argument to just say, let's throw ice, under the bus and just everything is bad about ice. That's not true. Let's use some of the good parts of it, recognize what we know in the research about the not so good. What are the limitations of the research? What are the limitations of the technology? How do we apply this every day in a practical way? Everything you said today is just hitting home with me on the practicality of things. And you can't, using it for 3 hours in a captured audience on a bus in 21-year-olds. These are really important things that people just read an article or they see an advertisement and they go, oh, this must work because the company told me that it works, so it must work all the time. That's not the case.
Well,
So,
I know you have another podcast on nutrition,
uh-huh.
but I'd just like to touch on,
Yeah.
so our first recovery research that I got involved with was with cherry juice back in 2005, 2004, 2005 with Declan Conley. And cherry juice is now a standard part of recovery in most teams, but cherry juice is actually pre-covery, it's not recovery. You
Hmm.
need to take it before the exercise, not after. So there's actually a position statement come out on nutritional interventions for recovery in soccer, and it said cherry juice doesn't work. because it cited a study that gave the soccer players the day after the game. And I'm going like, well, the horse is already bolted.
Yep.
But that line of research is all about dose. So I was the last person in the world who thought cherry juice would have any impact on recovery. I said, are you kidding me?
Yeah.
Food affect. So the affect not, you need food for recovery, glycogen repletion, protein resynthesis, but muscle damage is something totally different. And you're telling me something that you eat is going to affect. And so what got us on that was, well, how much of a food do you need to eat to get a medicinal effect? So if you look at resveratrol in red wine, resveratrol is an antioxidant, and everyone says, oh, you drink red wine, it's got antioxidants, resveratrol, it's been shown to have medicinal effects. I used to say you would need to drink 100 bottles of red wine a day to get a medicinal effect from resveratrol in red wine. A recalculation said it might be closer to 1,000 bottles. So it's not a practical intervention unless you've got 10 livers. So when we looked at the cherry juice stuff back in there's a publication in 2006, but they'd started the research before that. They showed that if you were eating a bowl of cherries a day, and there were 50 cherries in the bowl, it reduced some of your systemic inflammatory markers. So I went, okay, so if you eat 50 cherries, it has some type of a measurable effect on something that may be important, reducing systemic inflammation and some other blood markers. So I asked the people developing a drink, well, it's a fresh drink, so it's probably pretty potent. Many cherries are in a bottle. They said about 50. I said, well, you probably destroy some of the active ingredients making the drink, even though it is a fresh drink. So let's give them 2 bottles a day, because 50 works fresh. Bottle may not be as good as fresh. So we went with 2 bottles a day for 4 days. Then we exercised the people and gave them it for the days after as well, because we didn't know if it was a pre-recovery or recovery. We did both, and lo and behold, it worked. And every study since that has been based on that 2 bottles a day for that fresh drink. And then there's a lot of research from concentrate drink, and they calculated that there were about 90 cherries in a serving, and they did 2 servings a day, which was 180 cherries, because they figured, well, this isn't from concentrate, it's probably less potent than the fresh. So and there's now 3 people have done their PhDs on that concentrate drink. We've done and it all comes from one study that showed if you eat 50 cherries, so that's where it all. And that harps back to, you need to know what the dose is. So what dose might work, whether it's a nutritional intervention, a cryotherapy intervention, a massage intervention. We have to know what and when. Is it pre-recovery versus recovery?
Yeah, and the baseline assumptions are really important that you make. Sometimes we make false assumptions that drinking this stuff after is the part of the recovery. That's a faulty assumption that discredits anything after that. And then that's why we need to do a little bit more, I think, on the back end rationale with questioning, why are you doing it after? We need to be doing it before, because again, it's not just the dose, it's the assumption of when to apply it as well that we need. And so there are these interventions out there that we may be saying, oh, this doesn't work. Research says it doesn't work. You got to question, are you doing the right technique, the right dosage, the right time? There's so much more we need to know. And we're just
that's why I don't really like meta-analyses, as you know. I don't like because you're not comparing apples to oranges, you're comparing apples to pork chops. I mean, it's just, the nuances that go into the design and what was done in a study. And like Tim Noakes in South Africa had a great line. Well, it was actually an anonymous line in a review of a paper where he was supporting publishing our paper, and another reviewer didn't like it. And he wrote pretty much not to the authors, but to the other reviewer, the perfect study exists only in the minds of those who do no research. And I think and a lot of people doing meta-analyses are doing them never having done research in those areas, and they don't know the nuances of the individual studies and how you execute them, and how this is very different from that study. It might say, oh, well, they measured strength or they measured this, and says, no, but they didn't do it this way, and they did it that way. Very different thing, and
Huge.
that's a problem.
Another pearl for my research methods. This is exactly the point that I make with uh, meta-analyses, even systematic reviews, in the fact that you really need to know what these treatment parameters are when you're trying to compare apples to apples, and you cannot just lump everything in with the same treatments depending. And this is one of the issues I had with my kinesiology tape evaluations, where that no one used the same application of the tape for the shoulder. There were 7 systematic reviews on the shoulder, and all of them used different applications of tape. How can you put those together? I mean, you can globally say that no treatment was, the one thing that actually worked best, but they were so heterogeneous in how they were applied. It really there's no need for these meta-analyses when you can't take that into consideration. And then and I agree with you I agree with you to a certain percentage with meta-analyses, because I'm sick and tired of seeing, a meta-analysis with an N of 2. Oh, we just couldn't find enough that fit our inclusion criteria. Well, don't publish it then.
Well, my line is, when I get reviews of my editorial functions and I see that, my reply is, this is a great paper. It's a great justification for an actual research study. It's not a justification for a review paper.
Beautiful, beautiful statements. Well, Mal, you've really hit on a lot of the same parts of not just recovery, but which we started with, but what the things that I hope people take away from this are the things of underlying science and research that we really need to pay attention to, using the science of recovery and what's out there as kind of the mechanism for teaching people how to be better consumers of research, but also putting more ideas into the heads of potential researchers and clinicians on things that we still have a lot of questions on how to interpret these things. But it's really important that we do our homework, that we don't just read the last line of the abstract, that we don't just look at the ad, that we don't just listen to somebody on the stage tell us this.
Yeah,
Be critical, be skeptical.
And I get annoyed when I hear the editor of BJSM asking people to tweet this, tweet that, tweet that. And I'm going, you can't do science on Twitter. Those are one-line opinions. Science is not opinion. Science is data. Anyone can have an opinion, but not everybody has data.
That's fantastic. I'm going to have to use that quote as the last thing on this podcast. Thank you so much for taking the time this morning. We appreciate it.
Always good to talk with you.
You too, buddy. All right. Well, take care. Thanks everyone for joining us. This has been a great podcast, and hope that you'll join us for the next one. Thanks, everybody.